So starting into the wrist and hand, and interestingly enough, the ankle and foot were in the same chapter and the wrist and hand are in two separate chapters. That doesn't mean we're going to do twice the amount of work, but just like we didn't go into super detail on the foot, we're not going to go into super detail on the hand either. We're going to talk about the osteology and some of the motion in the hand, but we're not going to really dwell on the intrinsic muscles. We're just going to talk about them in groups. So hopefully that will meet with your approval. So we're going to start with osteology and wrist motion and stability a little bit. So the wrist has to be pretty stable, but also pretty mobile, right? It's one of those areas of the body. So of course, I want you to be able to identify the joint types and the motions available at the radiocarpal joint and the midcarpal joint. So similar to the foot where we have the tralocrural joint and the transverse tarsal joint, the radiocarpal joint and the midcarpal joint are analogous to those. Where I want you to be able to identify the bony landmarks. We're going to talk about the purpose of the retinaculum for stability and the structures that make up the carpal tunnel and what passes through the carpal tunnel, and the carpal bones and which structures they articulate with. So the carpal bones have a lot of little rhymes that go with their little mnemonics that go with them. So I'll share a few of them with you, and you might have your own that you like to use. They're all really palpable, just like the foot is really palpable. The hand is really palpable too. And I actually did a little video. I don't remember when it was, a year ago, a couple of years ago, of palpating the structures in the forearm and hand. So hopefully you'll find that helpful. So there in the wrist, there are two major articulations. The radiocarpal joint, which is the radius articulating with the proximal row of carpals, and the midcarpal joint, which is the line between the proximal row of carpals and the distal row of carpals. There's the ulnocarpal space. It's not a joint. There's an articulating disc in there, but it's just distal to the ulna. So it's not considered a joint. It's a space. And we'll talk about it. Very, very little, but we'll talk about it. So just like there's specific terminology with the foot, there's also some specific terminology with the hand. So the anterior hand is the palmar surface, like the palm of your hand. The posterior surface is the dorsal surface of your hand. So the palmar surface, the dorsal surface. So palmar is synonymous with anterior and dorsal is synonymous with posterior. I don't care which one you use, as long as you use the correct one for what you're trying to describe. And you need to be able to know what other people are saying as well. So the distal radius and the ulna form a concavity that articulates with the proximal row of the carpal bones. So it has 2 degrees of freedom, so it's basically a condyloid joint. The concavity is bordered laterally by the radial styloid process and medially by the ulnar styloid process. But that ulna doesn't really articulate with the carpal bones. There's a space there. So the radial tubercle, it's also called Lister's tubercle. It's a bony projection on the a dorsal aspect of the distal radius, and it guides the direction of some of the wrist and thumb extensor muscle tendons, which run on the dorsal surface, or sometimes you can call it the extensor surface of your hand. So the distal radial tubercle is palpable, very easily palpable, in fact, on your wrist. And it's really easy to find on a bone too, on a bony model. So the proximal row of carpal bones includes the scaphoid, lunate, triquetrum, and the pisiform. The pisiform is actually a sesamoid bone that's embedded in the flexor carpi ulnaris tendon, but on bony models, it's attached to the triquetrum, just so it doesn't fly away, because bony models don't have tendons. The distal row of carpal bones includes the trapezium, which is the bottom half or the proximal half of the saddle joint of the first carpometacarpal joint. The trapezoid, which articulates with the second metacarpal. The capitate, which is the captain of the hand, if you want to think of it that way, and it articulates with the third metacarpal, and the hamate, which articulates with the fourth and fifth metacarpals. So the bones within the proximal row are loosely joined, and strong ligaments tightly bind the distal row. So the proximal row has to be loose to give us the motion. The distal row has to be tight to give us stability in our hand. So just like the foot, the hand has arches, but since we don't walk around on our hands, they're not quite the same sort of weight-bearing type arches, but that distal row stability gives you a rigid base for articulations with the metacarpals, and that gives us mobility in our hands. So our hand arches are important for grasping and holding on to things. That is a key element in our function as human beings. So the carpal tunnel, it's partly formed by the transverse carpal ligament, which bridges the palmar side of the carpals. It serves as a passageway that helps to protect the median nerve and the tendons of the extrinsic flexor muscles of the digits. So the flexor muscles are super important in that gripping action as well. So they have their own little protection area in order to protect them. So the bottom of the carpal tunnel is all those carpal bones, and the top is the transverse carpal ligament. So the transverse carpal ligament runs right across the palm of your hand, and a lot of times that's inflamed, or the whole area is inflamed in carpal tunnel syndrome. So we'll talk a little bit about carpal tunnel syndrome, but we'll talk more about it in other classes. So the radiocarpal joint, it's the proximal concave, it's the concave surface of the radius and the articular disc that is between the ulna and the carpal bones. The distal part consists primarily of the convex articular proximal surfaces of the scaphoid and lunate. So you get the concave radiocarpal joint on the convex scaphoid and lunate. So approximately 80% of the forces that cross the wrist pass through the scaphoid, lunate, and radius. The scaphoid is the most commonly fractured carpal bone because of all those forces going through it. The lunate is the most commonly dislocated carpal bone. So, and that makes sense. They're right in the line of fire, right in the line of force. So the ulnar located carpal bones and distal ulna are less likely to fracture from falls because they're not in the direct path of weight bearing. So that the ulnocarpal space is a relatively wide space between the distal ulnar and the ulnar carpal bones. So it helps buffer those forces that cross the wrist. So if you fall on your outstretched hand, you're going to fracture your radius, your scaphoid, or your lunate. Your the ulnar located carpal bones, the ones on the medial side, are relatively protected by that ulnocarpal space. So the midcarpal joint separates the proximal and distal row of carpal bones. The most prominent articulation is between the head of the capitate and the socket formed by the distal surfaces of the scaphoid and lunate. They're sort of a U shape almost, and the capitate just sockets right in there. So really the capitate is sort of the center point for the all the movements of the wrist. And that's why I call it the captain of the hand. I also call it the captain of the hand so I can remember the name capitate. So the wrist joints are, like many of our joints, enclosed within a fibrous capsule. And the capsule is thickened by intrinsic and extrinsic ligaments. So extrinsic ligaments have proximal attachments outside the carpal bones, but attach distally within the carpal bones. Intrinsic ligaments have both proximal and distal attachments located within the carpal bones. And we're going to talk about one of the structures, but I'm not going to expect you, besides the transverse carpal ligament, we'll talk about one more. And I'm not going to expect you to know all the ligaments for the wrist. Suffice it to say, there are lots of them. So as a group, the intrinsic wrist ligament, so we're going to talk about them functionally as a group. As a group, they interconnect the carpal bones and they help transfer forces between the hand and the forearm. This is a common theme in the lower extremity and the upper extremity, the transfer of forces. The intrinsic ligaments also help maintain the natural shapes of the radiocarpal and midcarpal joints to minimize joint stress during movement. That's pretty important, right? So normally when you compress your wrist, like when you lean on your hands, the wrist remains stable. But if you get damages either from a large force, like falling on your hand, or from like wear and tear, arthritis, aging type things, it can significantly destabilize your wrist. So if someone comes into PT with a weak, painful wrist, we're typically going to treat them with strengthening, pain relief measures, education on wrist protection, and splinting. So that's a really common, probably something for either someone who's had an injury or someone later in life to come in with wrist or first carpometacarpal instability or arthritis. So it can be very painful, and it's something that people will often seek treatment for because it affects their day-to-day life. So the osteokinematics of the wrist involve flexion and extension and ulnar and radial deviation. So ulnar and radial deviation are just the hand special words for ab and adduction. The wrist can circumduct, combining those four motions, but it does not typically spin in a circular motion relative to the fixed radius. That'd be kind of cool if we could do that, but we can't. Our wrists just don't go that way. Pronation, well, I don't know how stable that would be, but anyway, it's an interesting idea. You can entertain it in your mind, but the wrist doesn't do that. Pronation and supination are motions of the forearm and not the hand or wrist. So when we're talking about pronation and supination, it's the radius spinning across the ulna. It doesn't have anything to do with the hand or wrist. We often use the hand as a landmark for pronation and supination, palm up or palm down, because the wrist movement's axis of rotation goes right through the capitate head. The axis runs medially, laterally for flexion and extension, and anteriorly, posteriorly for radial and ulnar deviation. Just like flexion and extension in other joints, it's in a sagittal plane on a medial lateral axis. Ulnar and radial deviation, also known as ab and adduction, are in the frontal plane on an anterior posterior axis. The capitate rotates a little bit to direct the overall path of the entire hand, but it's not a voluntary motion, and there's no muscle that does that. It rotates in concert with other motions. So there are a lot of motions in our body that are not a voluntary motion, but they do it because of osteological reasons, like the screw home mechanism in the knee, or they're consequences of other motions. So that's the rotation of the capitate is a consequence of other motions. So from flexion extension, from a neutral position, the wrist flexes about 70 to 80 degrees and it extends about 60 to 65 degrees. Total flexion normally exceeds extension by about 15 degrees. So if you can touch your wrist all the way to your forearm, you have hypermobile joints in your wrist. If you're easily standing on your hands, that's beyond normal extension. So, you know, I've done it. We've all done it. Stood on your hands, right? Or tried it at least. We're expecting more of our joints than they're really designed to do. The extension is limited by tension in the thick palmar carpal ligaments and the carpal bones making contact with the dorsal side of the distal radius. So it's supposed to stop where it where it is, we're not supposed to push it past that. But we have that flexion extension, more flexion than extension in general. But as I've said before, it's not, if you're outside of the normal range, it doesn't mean there's something wrong with you. It just means that you're outside the normal range. So radial and ulnar deviation on average from neutral position, which is anatomical position, full ulnar deviation is about 30 to 35 degrees. And radial deviation is about 15 to 20 degrees. It makes sense that there's more ulnar deviation because there's more space in that ulnar carpal space, right? Maximum ulnar deviation is normally twice that of radial deviation because of the void created by the ulnar carpal space.